So I'm Marcia Stefanik. We're going to put up a little wisdom slide for you really quickly that we introduced earlier today. We're not going to go through it, but I'll just tell you that this is the 7th annual Women's Health Forum that we are doing now in partnership with Health Matters. And the Wisdom Center is a center that is really focusing on advancing human health across the lifespan through research and education in women's health, biology of sex differences, and gender differences. And we're going to start with Susan Sweater, who is... oh, there it is. Okay, this is the slide we're looking for. Dr. Sweater is a professor of dermatology and director of the Pigmented Lesion and Melanoma Program at the Stanford Cancer Institute and the VA Medical Center. She's a long-term colleague. She's doing amazing work on sex differences in melanoma incidence, survival, and prevention. And so I'm going to pass it over to her. And when she finishes her talk, you can ask questions, and then we'll move on to the second talk. Oh,
I've got my, yeah, and then Marcia, can I have the clicker?
Oh, yes.
Thank you so much. It's a pleasure to be here today, and let's just see if it works. Wonderful. So as Marcia said, I'm going to talk about some of the differences we see between men and women in terms of their new cases of melanoma, the incidence, how they survive with melanoma, and then also what we're now seeing in terms of prevention of melanoma that may differ between the sexes. So this year in 2016, we'll see over 76,000 cases of invasive melanoma. That's potentially fatal melanoma, though we'll only see about 10,000 deaths from disease overall. It's the 5th most common cancer right now in men and the 7th in women. But what we've seen over the last 10 years or so is this alarming trend of melanoma incidence, the number of new cases, which has dramatically risen in younger women, women under the age of 40. And this is what we call a birth cohort effect. These are individuals born after the age of 1960, or after the year 1965. We've taken a look, this isn't going to be genetic or host factors, so we look for environmental reasons, and really the only thing that may be causal is the use of tanning beds, which became prevalent in the 1980s. And just taking a look at this graphically, I don't think I've got a pointer here, but you can see this is looking at different strata of women from 1983 to 2007, and every age group of young women we're seeing under the age of 39, we're seeing melanoma incidence rates go up. So what do tanning beds do to your skin? Well, they emit mostly UVA, but they also emit UVB. We say that using a tanning bed for about 30 minutes is equivalent to baking on the beach for a day. The UVA is 4 times stronger than natural sunlight, and the UVB is twice as strong. And we know from epidemiologic work that's been published worldwide now over the last decade that melanoma will double the risk of the non-melanoma skin cancers, the basal cells and squamous cells. And then for melanoma, the risk is even higher. So if you've ever used a tanning bed, both in men and women, your risk is about 15% higher. For those who start using it before the age of 35, that risk can be about 75% higher. And through some mathematical calculation, folks have actually estimated that each time an individual, and generally these are young women, uses a tanning bed, their risk for melanoma goes up about 1.8%. In 2011, California was the first state in the nation to enact the ban for minors in terms of tanning beds, which was terrific. And this was based in part on some of the work we've done with colleagues at the Cancer Prevention Institute of California to really help hone in the risks of tanning. We now have 13 states, and as well as the District of Columbia, which have limited tanning for minors, but still obviously a lot more work to do. Before the California tanning bed, again, working with our colleagues at CPIC, we took a look at young white women with melanoma incidence, the number of new cases, and actually showed that those young women who had the highest ultraviolet radiation and the highest socioeconomic status, so were more affluent, had the highest rates of melanoma, about 80% higher than those who had high sunlight exposure but low socioeconomic status. So this suggested that affluence and related lifestyle behaviors, likely including tanning, were contributing to melanoma perhaps more than sun exposure alone. And again, that was a very important paper that helped to promote this tanning bed ban in young women. I love this work. This is done by colleagues of mine out of NYU. And as we saw melanoma incidence in both men and women increase astronomically in the latter half of the 1900s, they correlated with this with what's happened with clothing overall. And again, I wish I had a pointer, but everybody can see how it's become less and less. Kind of ending here, I can tell you that's not a bikini from 2000. My girls' bikinis are much smaller than that now. And we're even ending up here with Sean Connery's. So, I think we could get into different lower clothed areas in both men and women, but I think it really is a nice correlation to show that tanning behaviors overall, both from natural and artificial light, have contributed to increasing melanoma rates. So we have obviously a rationale to prevent melanoma, and most melanomas in fair-skinned individuals worldwide are related to excessive sun exposure. So this is why we talk about primary prevention. How do we stop this disease? So aggressive sun protection, sun protective behaviors are really what make a difference. And we also know that most individuals get the majority of their sunlight in their younger years. And you think about it, when you're in your 20s, you finally have a job, you're working inside, you're not going to be outside to the same degree that younger individuals are, except if you're an athlete. And we've taken a look at sun risks in athletes as well. So we know that it's important to prevent the melanoma and other skin cancers via sun protection, but until recently we didn't have any data to even show that sunscreen was effective. And in 2010, the very first and only randomized controlled trial looking at sunscreen use showed that it could prevent melanoma down the line. And this was a study out of Australia where the rates of melanoma are the highest in the world. Here, conducted from 1992 to 1996 using an older sunscreen, so not even as effective as our broader spectrum ones of today, having individuals 800 apply it from the face and the arms only every day, compared to those who used it on an optional or non-basis. And again, the risks of melanoma then 10 years after this 4.5-year intervention of the sunscreen use showed that melanoma rates were down by about 50% in the daily users, including areas of the body that they weren't instructed to apply sunscreen on, but suggesting that they applied it to more than just the face and arms. And so what we learned from this is that if we were to extend this study, which was limited to adults between the ages of 25 and 75, to younger age children and adolescents, we'd probably make a much bigger difference. Now, about melanoma deaths this year, as I mentioned, this is the first year we're going to see melanoma mortality rates of over 10,000 in the US this year. And almost 2/3 of the deaths we see are in men compared to women. And I'm going to talk a little bit about why we think this is happening. What's critical with melanoma is that we detect it early, and that's called secondary prevention. If we detect the disease when it's thin, here, stage 1 tumor, the survival tends to be remarkably good compared to those who have advanced disease. Even though we've made progress in treating patients with advanced melanoma, our goals are to detect it early. That's where we'll save most lives. It's been said that melanoma writes its message in the skin with its own ink and for all of us to see. And so we as cancer control experts in the field always wonder why this visible skin cancer is so hard to detect early for many patients. And when we talk about how we can reduce deaths of melanoma, it really involves an understanding of the biology. Are there differences in the tumor types we see between men and women? Are there differences in the epidemiology? Who gets the tumor? Who's more likely to die from the tumor or survive with it? And who, in terms of sociology, whose behaviors are going to make a difference in terms of prevention, response to therapy, and so on. And what we know with melanoma is that if a doctor or other provider detects a melanoma when it's not symptomatic and not bleeding on the skin, it tends to be much thinner than when a patient comes in with a bleeding mole. And that tends to be a much more dangerous and potentially more fatal tumor. We also know that individuals with lower education, lower socioeconomic status do worse from melanoma, lots of times related to lower access to specialty care. And then, of course, now what we're seeing is that middle-aged and older white men really are suffering a disproportionate mortality. So looking at this data from 1969 all the way to 2007, we're seeing astronomical rates of melanoma deaths in white men over the age of 65 compared to women in the same group, and also even in the middle-aged and younger groups. This is data from the AACR Cancer Progress Report of 2013. It's a little busy slide, but the right side are increases and the left side are decreases in both cancer incidence and mortality. And what we're finding is that, and this is still true, melanoma is only one of 3 cancers in men where the death rates are rising, and we're not seeing that in women. So we have a strong rationale to target older men for early detection strategies. About 60% of our melanoma deaths occur in white men 50 years of age and older, and we know that men are less likely to navigate the healthcare system as effectively as women. They don't participate in cancer prevention programs to the same degree. And so several years ago, we conducted a study looking at targeting and reaching out to middle-aged and older men, and found that it's critical to involve their spouses. And in this study, predominantly older men, it was largely female spouses and partners, to get them into the doctor, to ask for a skin exam, and particularly just to look at the back, because about 1/3 of the melanomas we see in men are on the back. So if we simply lift up the shirt and every patient who's coming in and having their heart and lungs listened to by their primary care doc, we'd probably go a long way to detecting thinner melanoma. And in terms of the biology, we also see a different subtype of melanoma that's a little more prevalent in men called the nodular subtype. And this tends to elevate, grow, bleed, ulcerate. It doesn't tend to spread out or laterally or horizontally. It tends to actually just dive deep into the skin. So it's a tough one to detect earlier, and we often say it has the Band-Aid sign. So every time an older gentleman says, well, I got a flu shot and I've got a spot there, I said, let me see what's underneath it. Very important. So the concept, though, that melanoma, it could be more malignant in men was actually raised by Wallace Clark, who was a melanoma specialist, in 1969. And we have attributed this to the concept that, well, men don't get into the doctor as much, it's a delay in diagnosis, so we're picking up thicker tumors that do worse. And it's only been in the last 5 years that a real biologic difference between the sexes in terms of survival has been proposed. And this came out of data from Europe that had suggested that there was a female survival advantage for melanoma. And these are predominantly older women over the age of 50 in women who are on trials, in men who are on trials getting the same treatment, and they started to match it according to the subtype of the tumor, the location, and et cetera. So what we did at Stanford, in conjunction again with colleagues at the Cancer Prevention Institute of California, CPIC, is to actually look at the issue of melanoma survival in younger individuals under the age of 40. Because here you don't have as much of those behavioral differences. Most young men and women don't go to the doctor apart from women in their childbearing years. And so what we did is take a look at all of the melanoma cases that we could that were invasive disease. Those are potentially fatal. We looked at the melanoma-specific deaths, and we found 26,000 invasive melanomas and about 1,500 deaths. Males accounted for 40% of the overall cases, but over 60% of the melanoma-specific deaths, which was not surprising. But what was surprising is that when we took a look at all of the factors in young men versus young men were 55% more likely to die from melanoma than were young women. And this is including when we matched it for thickness, location on the body, the subtype of the melanoma, and even if they had a regional or lymph node disease or distant disease. And so what was alarming to us, and this is kind of a busy slide, is that even locations like the leg, which is traditionally a pretty good location for melanoma, we saw that men were 67% more likely to die, or if they had regional lymph node disease, 74% more likely to die. And there are potential reasons for this. We're not sure why this is happening, but we don't know whether there's a protective factor in women or a factor in men that stimulates melanoma to do worse. And obviously we think sex hormones could be an explanation, and women have more estrogen. Is that the reason? We don't think it's estrogen, but there is some preliminary evidence that testosterone and other androgens might be at play here. We now are looking, though, at whether the immune system might actually differ between men and women. And we're studying this at Stanford. I'm working with my colleague, Dr. John Sun Wu, and Dr. Holden Maker, who runs our Human Immune Monitoring Corps, to take a look at whether there might even be a difference in between the sexes, between men and women, in how our T cells work to fight cancer, and whether our T cells are more long-lived and have more memory in women compared to men, such that the T cells, which kill cancer cells, are actually doing a better job in terms of surveillance and getting rid of any existing cancer. So this is, I think, a very interesting avenue for research, and we really need to hone in on this. Finally, I'm just going to conclude a little bit with chemoprevention. Now, chemoprevention is the term that's traditionally been used where we are taking safe and tolerable drugs and vitamins, over-the-counter agents, to prevent a cancer. Fruits and vegetables, things like that. The term has now been changed to therapeutic prevention or even precision prevention because we're not using chemotherapy, and so that gets confusing for patients. But it's another type of primary prevention. And melanoma is really an ideal target for therapeutic prevention, particularly in young individuals who stand to lose the most if they get a fatal disease. And we also have biologic markers for melanoma. These are clinically typical nevine patients. I see a lot of these in our pigmented lesion and melanoma program. These individuals are at increased risk of melanoma based on their mole pattern alone. So there are clearly populations at increased risk for melanoma whom we can target for therapeutic prevention. A number of agents have been looked at. We had hoped that something as simple as statins and fibrates, which are used quite a bit for cholesterol and triglyceride lowering in individuals, could be helpful. They appear not to be. Non-steroidal anti-inflammatory agents and aspirin are now being looked at. We've done some studies with this. Green tea, polyphenols, other antioxidants such as sulforaphane, which is in broccoli, thioredoxin reductase, other antioxidants can be taken and actually be proven to show that they may prevent cancer. And we'd even looked at N-acetylcysteine, which is a drug that's very safe to take, but now looks like in melanoma models it makes melanoma do worse, so we're not looking at that anymore. Vitamin D is also very interesting, whether that has cancer prevention effects. And so when our patients are careful about the sun following a melanoma diagnosis, and we want them to be careful about the sun, we usually advocate taking vitamin D supplements. So nonsteroidal anti-inflammatory agents, or NSAIDs, are both aspirin and non-aspirin typed, and they actually have been shown to decrease the incidence of metastasis and mortality in a number of cancers, including melanoma. We presume this has, there are different mechanisms of action, including the reduction of the prostaglandin synthesis and reduced inflammation. And so what we did in conjunction with Marcia Stefanik and others is to actually look at the Women's Health Initiative data, which is a rich data set of hundreds, well, if you add both groups together, the intervention and the observation, it's over 100,000 women who have actually been observed for cancer risk, mortality, other issues in relationship to interventions on those arms that got vitamin D and calcium supplementation, or hormone replacement therapy, where there were issues with cardiac and breast risk came about. But there was an observation arm in this study of individuals who weren't on the intervention arm, who also had cancer outcomes and cancer incidence tracked over time. And so our hypothesis was based on a case control study that came out of Harvard that had estimated a nearly 50% reduction in melanoma risk with the use of nonsteroidal anti-inflammatory agents, and particularly with aspirin, when it was given for over 5 years. And the trend in that study was focused on women. In other words, the benefit seemed to be in women and not men. So we took a look at this issue in the 60,000 plus patients in the WHI study, looking at their prescription use, or non-prescription use in this case, of ibuprofen and aspirin and other drugs. And then there was ways that this could be validated to determine how long they'd taken the drug. And over time, over a median of 12 years of follow-up in the data, 548 melanomas were detected, and about 25% of the women in the study had used aspirin. Of those, most of them were on extra strength and not low-dose aspirin. And what we found very importantly is that the women who'd used aspirin in this cohort of patients had about a 21% lower risk of melanoma compared to non-users. And we didn't see this for the ibuprofen, non-aspirin, non-steroidals, but there was a lower prevalence, a lower usage of that drug compared to aspirin. So just taking a look at here, again, the duration of the aspirin use in women was also relevant. And these are postmenopausal women over the age of 50. And so we're finding over 5 years of use associated with about a 30% reduction in melanoma risk. And again, we matched this for a number of factors which didn't appear to matter. In other words, it's important to look, obviously, at sun exposure, vitamin D intake, and other things. This is not a randomized controlled trial. We're not telling women as a result to go out and take aspirin, either baby aspirin or regular strength aspirin. That's got plenty of its own other risks. But it is, I think, a signal that we might be seeing some differences between men and women in terms of how we can even prevent skin cancer, melanoma, and other cancers. And my last slide just relates to this concept of precision prevention. And so I think this is an avenue that's ripe for further research. It's something I'm very interested in. If we can find the right agents, or agents which are safe and tolerable, and have individuals take these in addition to sun protection, we'd probably go a long way to reducing the incidence of melanoma and most certainly mortality. Thank you, and I'm happy to answer questions in about, I think, 2 or 3 minutes. Anyone have any questions? There's usually a lot of questions about sunscreen types and vitamin D. Go ahead.
There are mics running around.
Okay.
I would like to suggest, with a network of studies for women, and I congratulate you because recently I heard that there was no money for women's studies, and it was awful to hear. But anyway, if anything can be done to protect children, there are playgrounds. You know, people are making money out of childcare.
Right.
And it's disgusting to see. They care less about putting a tarp, protect them, and for them to sit in hot structures.
Yeah. There are quite a bit of data to support that we need to do more of what Australia and New Zealand do for aggressive sun protection in children. And if you go to those areas of the world, you will see, kids covered up fully, hats, shade structures. There hasn't been, there's a call to action from the Surgeon General, and part of this relates to primary prevention in school-aged children with the increased use of shade structures, clothing, protective clothing, sunscreens, and it's frustrating that it's taking so long, as it's also frustrating that some of the better sunscreen ingredients have yet to be FDA approved that are in other developed countries that actually block all the way through that far UVA spectrum. But I'm in complete support of what you've said. There are efforts to do this around the country in different states. We certainly have statewide efforts as well. We have a program called Sunsport, as I alluded to, that's looking at athletes who get about 10 months of significant sun per year. It's equivalent almost to tanning bed use, and how we're trying to also work with athletes athletes and children between the ages of 10 and 20 who sort of lose the message of sun protection in their adolescent years as the parents have less control to get sunscreen on them. I know that with 2 teenage daughters. Any other questions? Go ahead.
About sunscreens, could you give us some information that we can
Yes.
use about sunscreens?
Sure. So just quickly, and tell me when I'm done, Anne-Marie. So the chemical sunscreens, which contain ingredients called avobenzone and octocrylene in the US, are more effective than the physical sunscreens, which contained micronized zinc oxide and titanium dioxide. Most people think those physical sunscreens should block out the sun. There is no sun blocker unless you use completely opaque zinc oxide, which no one's going to use. It's not cosmetically elegant enough. In other countries, there are better UVA filters. They haven't been FDA approved. There's been a 10-year process to get them into our sunscreens. They work significantly better in protecting us. But in general, the chemical broad-spectrum sunscreens in the US with an SPF of 30 or more, and we say SPF 30 because consumers put on less than half of what they need, should be pretty good in helping to prevent skin cancer, photoaging, and sunburn. And I'm happy to answer additional questions outside, I think, unless Marcia wants
Yeah, I
me to
think we need to move on to our next speaker, but thank you very much. So she will answer questions outside. So it's my great pleasure to introduce Amy Hsu, who's actually just lectured in my class last week, so I got to hear great stuff from her. She's going to do precision mineralization, how to maintain strong bones. You can come right on up here. And she runs a wonderful bone clinic. She's really one of our more recent wonderful stars.
Good morning, or good afternoon, everyone. So yes, my name is Amy Hsu. My topic is precision mineralization, how to maintain strong bones. And I focus on hormonal and bone health in the Division of Endocrinology here at our medical school. So my agenda today is I'm going to use a true-false format and hone in on 5 key concepts that I chose for you today in order to customize a plan for your personal bone health. And it discusses calcium balance in the body, the importance of vitamin D, to follow on Dr. Sweater's talk, the concept of bone fragility as it is associated with aging, and to talk a little bit about drugs, because this is what everyone's always interested in, that there are safe and effective drugs to use when needed. So, myth number 1. A normal blood calcium level in your reflects an adequate dietary calcium intake. Said another way by my patients, my calcium in my blood is fine, so that must mean I'm eating enough calcium. The truth is, blood calcium takes a big priority in the body, and it is very carefully controlled. And I will show you a picture of how it's controlled in the body in a minute. And the fact is that if you are not getting enough calcium by diet, by intake from the gastrointestinal tract, your body will take calcium out of your bone to subsidize the blood calcium. So the bottom line is a normal blood calcium does not necessarily mean that we're doing an adequate job on getting enough calcium in our diet. So this slide shows you how what contributes to blood and extracellular calcium. So at the middle of the slide, I have extracellular calcium. That implies the level of the calcium concentration in blood and in cells. And our body likes to keep that right around 9 milligrams per deciliter. It's very important for nerve and muscle health. Your most important nerve is your brain. Your maybe most important muscle could be your heart. So we really keep it very tightly there. The GI system, the stomach and the intestine, absorbs calcium throughout its lining. In times when there isn't enough intake by diet, the body will take it out of the bones through the work of parathyroid hormone. So parathyroid glands are these 4 small glands in the back, in your neck at the back of the thyroid gland. They're not really related except in location. So the parathyroid glands turn on, release hormone called parathyroid hormone to release calcium from the bones into the blood when you need it. So you can see here, if it's not coming from the gastrointestinal tract, it's going to come out of the bones, which is fine until with aging, you're taking it out of the bones also. So it's like a double whammy. What happens if you get extra calcium by diet or elsewhere? The kidney is very smart. It excretes the excess in your urine. And another key fact I highlighted at the bottom of the slide here is that 99% of your body's calcium is stored in the bones. Only 1% is in the extracellular region. Calcium requirements vary by age throughout the lifespan. For adults, it usually ranges from 1,000 to 1,200 milligrams per day. And good sources are, most bioavailable sources are dairy, but there's a lot of other sources as well too. Here's a quick and easy way when you're in the grocery store to look to see which of your foods may naturally contain calcium or are fortified with calcium. So I'm missing my circle here, but if you look below the dark black, the second dark black line, you'll see there calcium 30%. I don't know if you can see that, but so what does 30% refer to? It refers to the United States recommended daily allowance. So in the US, our recommended daily allowance is pegged at 1,000 milligrams, so 30% of 1,000 is 300 milligrams. Pretty straightforward math. Another easy way is to replace the percent sign with a 0, so 30%, 300 milligrams. This particular nutrition label we took from the back of skim milk, and you just pay attention to the serving size, which is right at the top under nutrition facts. It's 1 cup, 240 milliliters, or 8 ounces. So said in another way, 1 cup of skim milk gives you 300 milligrams of calcium. Myth number 2. Experts agree calcium tablet supplements increase the risk of heart disease. This was big in the news about 5 years ago, and a lot of my patients are still talking about it. So the truth is that actually the experts do not agree. The link between heart disease and calcium tablets remains hotly debated in our field and controversial. And in fact, the majority of the evidence suggests no link. And there's a lot of different kinds of evidence out there, different quality of evidence, but the way I read it is there's not clearly a link. We do know that and have reasonable information that I believe is true, that high doses of calcium supplements in tablet form versus food form could be related with an increased burden of kidney stones. If you're an unlucky person, you already have other risks for kidney stones. Calcium tablets versus foods may not be so great. So the bottom line on calcium supplements is that, of course, while, as I showed you before with the calcium balance in the body, it's very important to maintain adequate calcium intake. If you can do it all by food, that's the best way. But it's sometimes difficult to get it with food. Good food sources are dairy, almonds, almond milk, soy milk, the dark green vegetables like broccoli and kale. But supplements are just that. If you can't get up to there all the way, then take a supplement as needed. But you don't need to take the full amount in supplements if you're doing a pretty good job on diet. And I have up here broccoli and then Cheerios. Cheerios are fortified with calcium. Total cereal is another one that's got 100% of the daily allowance of calcium in there. Myth number 3, calcium and vitamin D are absorbed together. So if I'm getting enough calcium, then I'm getting enough vitamin D. The truth is that it's actually pretty challenging to know what your vitamin D status is. And so I'll share with you the name of the test that you'd be asking for in order to have it checked out for you. Vitamin D, why is it important? You heard about it a little bit. What we do know, it's been very important in bone and muscle health. It promotes intestinal calcium absorption. So what does that mean? Vitamin D primes your intestines to absorb the calcium that you're eating. If you're deficient in if you're deficient in vitamin D, all that hard work you're doing to eat calcium is just going straight through the gastrointestinal system. So basically into your stool rather than being absorbed into the blood. So vitamin D is a key building block here. The sources are exposure to sunlight, and it actually does not require much. But as we don't want to get melanoma, dietary sources are another way, but actually you'll find that it's not that easy in diet. So sources I put here in the picture: salmon, tuna, egg yolk, which nobody's going to eat a lot of, and it's not that much in the egg yolk anyway, mushrooms, and some fortified dairy products as well too. So many of us will need to get supplements at the end of the day. While some people can eat plenty of calcium, it's harder to get enough D with your diet. So the 2 main forms are vitamin D3 and vitamin D2. D3 is also known as cholecalciferol, D2 ergocalciferol. To the body, they're the same exact thing. D3 might be a little bit more potent unit for unit, and D2 happens to be the one that is available by prescription. D3 tends to be more over the counter. But for your purposes, you can assume 1 unit to 1 unit roughly. And I'll give you some guidelines on the doses. So if you wanted to know what your vitamin D status is, a good way is to ask your physician to measure a blood test. It can be done any time of day, and it's called a 25-hydroxy-vitamin D. It's a reflection of the body's total stores of vitamin D. This is in contrast to a 1,25-hydroxy-vitamin D, which is the active form of vitamin D and the inappropriate test to look for your vitamin D status. So that's a common mistake that we see done sometimes, but it's the 25-hydroxy-vitamin D. Generally, we agree that most people should be about 20 to 30 nanograms per milliliter or higher. Individual supplemental requirements do vary, so it's not everybody's going to get the same dose and get the same results. Most people require anywhere from 0 to 4,000 international units a day, and that's pretty safe when we looked at populations. And the typical recommendations from our governmental agencies usually start at 600 to 800 IU per day. Many of the multivitamins that you'll be taking, the Centrums, the One-A-Days, many of them have this amount in it already. Myth number 4. Good nutrition and plenty of weight-bearing exercise can prevent age-related bone fragility. So I have a picture up here, fountain of youth, next exit. So unfortunately, I'm here to tell you that although we've done really well as a nation in reducing the rate of hip fractures from 1995 till now, the fact is in 2006, we still see age-related bone fragility. So just to put it in context, in 1995, we started placing some emphasis on screening for osteoporosis because the first medications became available, and then we had some emphasis on nutrition and weight-bearing exercise. So in that amount of time, from 95 till now, we've managed to decrease the rate of hip fractures by 8% for men and 14% for women. That's pretty good. We've done pretty well for ourselves. But the fact is, we're still breaking, and that probably is just Mother Nature. We'll see, but in 2016, like I say, we're still breaking as we get older. So there is more to aging bone than just nutrition and exercise. So this is a graph here. On the left-hand side, I have men. On the right-hand side, I have women, showing you that fragility fractures do increase with each passing decade. So you'll see here on the x-axis, the lower axis is age. On the y-axis is the annual incidence per 1,000 people of fractures. Blue lines represent fractures anywhere, fragility fractures at any of the important bones of the body, including the spine, the hip, the arms. And then the red line represents hip fractures. They were taken out especially because there's a lot of morbidity after hip fractures. So you can see for men, it's kind of low until the 60s, and then there's a tail up, and by the 70s and 80s, it's a great increase up to 20 to 30 per 1,000 men per year getting fractures. And for women, it starts a little bit earlier. You can see they're right around the average age of menopause in the 50s and goes up exponentially with each passing 5-year increment there. And this is recent data. This is from 2010, looking in the United States. Okay, this slide I chose to put here just to hammer home, if you have experienced one fragility fracture or your friend has, take it as a warning sign to talk to your physician and take stock of your nutrition and your other lifestyle habits. So it's showing you, a woman progressing over the years, and I'm going to just read it to you. This is from the National Osteoporosis Foundation. While the progression of bone loss leading to osteoporosis, aged bone fragility, is gradual over time, once a patient experiences a vertebral fracture, for instance, the risk of a subsequent fracture can be surprisingly rapid. So take it as a warning sign. Why do we have more fragility with aging? It's an active area of research. There are a lot of changes that we've noticed. Estrogen certainly plays a role. That's why we see that big uptick after menopause. And there is a change in the natural cycle of bone remodeling and recycling. So we're recycling our bones all the time since youth until the last day of our lives. Every 10 years, we get a brand new skeleton. So there's always a crew of cells that's removing old bone and a crew of cells that's replacing new bone. And the bone remodeling, like I said, occurs throughout life. And with aging, however, the removal crew somehow gets a signal to go too fast. So it's not matched with the bone formation crew anymore. And it just, on net, results in less bone. So, okay. So myth number 5, and this is the last myth we're going to address. Bone drugs do more harm than good. And my patients say to me, I read about it in the news and it's not for me. The truth is we have a variety of drugs available. There's usually something for almost everyone, and when used at the right time and in conjunction with nutrition and exercise, they can be very effective and very safe. So this is a slide just to give you a flavor of what is out there. And I've divided it on the left-hand side into the bone drugs that act on the crew of cells that breaks down bone, right? These slow down the bone breakdown, slow down the bone removal. And on the other side, we have one drug currently approved for building bone faster. So I'm going to just read them to you. The first one is bisphosphonates, and these are the ones you've heard of, brand names Actonel, Fosamax, Boniva, Reclast. And I put an arrow there because everybody has questions about them. I have 2 slides about them coming up. The next one is denosumab, our newest one to market, also called Prolia. The next one in this list is selective estrogen receptor modulators called SERMs, and the brand name there is Evista, very similar to the breast cancer drug tamoxifen. And then estrogen could be considered a form of bone therapy as well, too. On the bone building side, so this enhances the bone construction crew faster and faster. There's only one drug right now, and it's called teriparatide. It's man-made parathyroid hormone, interestingly, and it's really a very interesting story that I'll tell you someday. It's called Forteo, but this is not necessarily first line because it's a daily shot. It's very expensive, and there's some other considerations. So not, we do use it, but it's generally considered second line. Though the physiology is very appealing. On this slide, it's not something you need to commit to memory. This is mostly to show you that yes, you can tailor something to your own needs. So what I have on the left-hand column is all the medications or supplements that are associated with bone health, and on the upper part, I show you segments of the body or segments of the population that do well with these drugs in terms of reducing fractures. So I see my red bar has shifted a little bit, but the red bar is to show you the bisphosphonates that I'm going to concentrate on, and those include the alendronate, Fosamax, Resedronate, Actonel, Ibandronate, Boniva, and Zoledronic Reclast. It should be just shifted down one line there. But the check marks mean that in human studies, it has been proven that this drug does reduce, and up to 50 to 80%, I will say, reduces the risk of fragility fractures. So you'll see there many of the bisphosphonates, the ones that have been somewhat maligned in the press lately, still have a very good track record for spine fractures, non-spine fractures, hip, wrist, steroid-treated patients, and men. So my point being here is that when it comes time for you to consider therapy, do advocate for yourself and point out to your physician, my fractures seem to be at this site, or I'm on steroids, or I'm a man. Which one might be the better one for me? Because maybe it's not a one-size-fits-all thing. I'm going to focus here on the oral bisphosphonates, like I said again, Fosamax, Actonel, Boniva. How do you take them? Compliance is really important. Empty stomach first thing in the morning with 4 to 8 ounces of water, no other liquid. So orange juice, coffee, not okay. And this is because it's hard to absorb this medication in the gut lining. For 30 to 60 minutes, you should remain upright with no other oral intake. Upright means you can drive, you can exercise, just don't lie back down and go to sleep. If this way of taking it does not work out for you, there are ways that you can dissolve it in water and make it like an Alka-Seltzer and drink it if you can't swallow pills. And there is one if you absolutely have to eat something first thing in the morning, like your coffee. There's one you could take after breakfast if you need to. And if it doesn't work by going through your GI tract for whatever reason, symptoms, or you just don't want to rely on your gastrointestinal tract, you can get it through the skin into an intravenous infusion. Very convenient, and a lot of people like that. So these are some other special concerns. I want to remind you, they are very effective. They can reduce your risk of fragility fracture by about 50%, generally very well tolerated. Potential side effects that can be kind of common, maybe 1 in 5, stomach upset and body aches. Sometimes it goes away, sometimes it doesn't. If it's not, you should speak to your physician about it. And then the extremely rare side effects, but have gotten a lot of play in the media, are these 2 things, and I wanted to show you one slide each. So one is called osteonecrosis of the jaw. What is it? I'll tell you. And then atypical femur fractures. Again, I'll show you a picture of that. So osteonecrosis of the jaw, what does it mean? So it's been associated with generally very long-term use of the bone medicine, the bisphosphonates, and in some unlucky people. Usually they have some other risk factors. But what it is, it's not jaw pain. It's not that your TMJ is flaring or that your tooth become a little bit loose. It's really an exposed bone of the facial region, mandible, maximal, or palate, oftentimes after a tooth has been extracted, but not necessarily. It does not heal despite 8 weeks of really good therapy from your dentist. So after the dentist has identified it and tried for 8 weeks to heal it, it's still not healing. And this does not qualify if you've had radiation therapy for cancer. there's something that's another risk factor for having this condition happen to you, but not necessarily related to the medicine. And what I have shown here on the left-hand side is you see that white piece with the ulcer, so that's exposed bone, and then sorry, that's on the left side. On the right side, this person, right lower jaw, had a molar pulled, and you see the gap there has not healed despite therapy. Atypical femur fractures, talked about a lot. A lot of my patients are very nervous about it happening. In fact, it's really, 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 really rare. Most physicians out there have never seen it happen to any of their patients. But I want to show you what a typical femur fracture looks like and an atypical, just so that you can distinguish them. So the typical femur fracture I have on the right-hand side here with the arrow pointing. So you see how there's a round part to the femur bone, and then it slides into a neck, and you can compare the two sides. One looks squashed together. So this patient of mine fell on her right side, and there's a fracture there. The bone broke and got squished. That's a typical fragility, age-related fracture. The atypical one associated with, it could happen outside of bone meds, but could be associated with bone medications as well too, is this one that was down in the shaft of the femur, and that red arrow is supposed to show you where it is, but it's a little bit far away. You can see there's a little beak. We call it like a bird beak on the side there. It's usually what patients will feel, and this is usually 7 years of therapy continuously in a row, will be a gnawing, deep bone pain. And it's bone pain that doesn't go away. And usually you will talk to your physician about that. Thanks. Okay, so my last two slides. So what do we, everybody wants to know, when should you take a breather from these bone medications? The initial course is generally 3 to 5 years. 5 years for the orals, 3 years for the IV. Do consider a holiday after that initial course. High-risk patients can safely continue. It doesn't mean that at year 6 the bone drug doesn't work anymore. The length of the holiday, no one knows. Currently, the most frequently stated timeline is about 2 years, but it could be 2 months, it could be 10 years, forever. But do advocate for yourself. Keep track of when you started and when you stopped, because it's really hard for your physician. Sometimes some physicians, it's hard for them to remember. So say, hey, I think I've been on my medicine for 5 years. Is it time for me to take a breather? Summary. So what we talked about with our 5 myths was that adequate calcium intake is needed to maintain your bone integrity. Adult calcium requirements range from 1,000 to 1,200 milligrams per day. Diet is preferred to supplements, though supplements can help you achieve your target if needed. Vitamin D promotes gastrointestinal absorption of calcium. Bones do become more fragile with aging. That's Mother Nature. And there are safe and effective drugs out there to use when needed. Thanks.
So I'm going to introduce our last speaker of the session, if I'm advancing it. There we go. Okay, so Rachel Mamber is a professor of psychiatry and behavioral science. She's also the director of the Stanford Sleep Health and Insomnia Program. She's going to be talking about sleep health, so hopefully you all stay awake for it, how life phases shape how we sleep. And I've worked with Dr. Mamber for many, many years, and I can tell you she's really an amazing scientist and researcher, and also is really very good at helping people with sleep.
I don't need this, I think. She's going. I don't need this. Good afternoon. Thank you for being awake. So I think I was introduced, and I would like to start by talking about what I'm going to talk about today. So I can talk about sleep for 2 days, not 20 days, maybe not 20 minutes. But so it was hard to choose what to focus on. So I'm going to tell you a little bit about basics about how sleep is regulated, so you have a framework of thinking about it, and many of the questions that you might come to your mind, you might answer for yourself once you understand it, and others, if we don't have time, I'll be outside, we'll be happy to answer. Then I will be talking about sleep in specific life phases, from pregnancy to parenting, the different age of kids, and the challenges it poses with respect to sleep, menopause, and retirement. I will focus then a little bit about what insomnia is and how it is treated, and where you can find help. So how is sleep regulated? So from the perspective of sleep itself, there are 2 processes. One process is the sleep drive, and the second one is the circadian clock. So the sleep drive is exactly what it sounds like. It's what drives us to sleep. It's sense us a signal that we need more sleep. And we experience it as sleepiness. And I'll talk about each of these processes in a minute, a little bit more in depth. The circadian clock is a biological clock that makes sure that we are awake during the day and that it permits us to sleep at night and helps us stay asleep at night. And I'll explain to you how these two things work together. So functionally, the outcome from that clock is stay awake. And if it's strong outcome, stay awake, then you're wide awake. And if it's whispering, stay awake, then most likely you'll be asleep. So what is the sleep drive? So from the moment you wake up, you increase your drive for sleep because your brain is busy doing things, and as it needs energy, and the byproduct of that energy then accumulates, and that becomes a signal. You've been awake for a long time to sleep. When the drive for sleep is very strong, you feel sleepy, and the stronger your sleep drive, the sleep that you will get will include in it the most deep stages of sleep, because as many of you know, sleep is not a homogeneous state. It's divided into REM and non-REM, and within non-REM all sorts of stages, but the part that's the deepest sleep is driven by this sleep drive. While you sleep, your energy in the brain is being replenished, and as a result, your sleep drive decreases. So this means that the deep kind of sleep is less likely to be in the second half of the night. And in fact, most of the deep sleep that we get happens within the first 90 to 1.5 to 3 hours since we fell asleep. So most of us are not deprived of this because the body makes sure that that's what we get. What is the circadian clock? Circadian clock is derived from Latin for about a day. And basically, it's sending, as I said, alerting signal. And at the beginning, across the day, it starts slowly increasing so that as your sleep drive increases, so does the alerting signal, making sure that you stay awake and you do what you need to do. Then, at some point in the late evening, it starts decreasing. And when it starts decreasing, it permits us to go to sleep. If we have a healthy sleep drive, under normal conditions, if we are not very anxious about anything, we are not supposed to do something else, we will fall asleep. Once we are sleeping, our sleep drive decreases, so does the alerting signal, so the balance remains in favor of staying asleep, and the sleep drive can do its work. About 1 to 3 hours before we wake up, the clock starts saying, wake up. And eventually, the sleep drive is low enough, the alerting signal is strong enough, and you naturally wake up. So that's kind of a cycle that happens every 24 hours approximately. Some people, it happens, their cycle is longer. Some people, their cycle is shorter. And it corresponds to, phenomenologically, some people characterize themselves as a night type, and other people characterize themselves as morning type. So what is the hallmark of a night type? A night type is a person that's the most important thing about them is actually what happens to them in the morning. They wake up, and it's very difficult to wake up. And it takes a long time to be fully awake. Right? So we all know of the adolescents that sleep in until 11 or 1 o'clock in the morning. They are most likely more of the night type. It's difficult to fall asleep until a conventional time, and they feel most productive in the evening. So they'll have a second wind. Will feel sluggish in the morning, thinking slow, most creative at night. The other extreme, we have morning type. They have hard time staying awake until a conventional evening time. They tend to go to bed in the early. They unintentionally doze off while they watch television or read or are in a concert. And they wake up early, and they feel most productive in the morning. This is largely biological driven, and genetically it's related to our clock gene that determines the periodicity of that circadian clock that we talked about. Most people don't fall into either one of these types and stay smack in the middle. So most people don't need to worry about it. But among people that come to me with problems sleeping, there's a disproportionate representation of people whose biological clock is misaligned with what they are trying to do. Getting older in and of itself does not significantly affect the biological clock. But the sleep schedule becomes earlier for a variety of behavioral reasons. So some of our behaviors impact our sleep. Our clock is very sensitive to light exposure, which allows us to travel across time zones. So we can go to Australia and readjust our clock on an average of 1 hour a day because our retina receives light and the brain has a way to process the light and shift the clock. So our system is particularly sensitive to what happens with light exposure close to the time that we sleep. So if we have bright light exposure before we go to sleep, it's likely to push our clock to later. And if we have bright light exposure first thing in the morning, it's likely to push our clock earlier. Having irregular wake time, like many people who work and have to wake up early for work but then sleep in on the weekend, it's like they move to different time zones every so often, and every week. And when that happens, the biological circadian clock is not as robust because it constantly has to adjust. So in order to sleep well, what needs to be happening from the perspective of sleep alone, and I'll amend this slide shortly, you have to have a strong sleep drive, which means no long naps. Naps are okay, but no long naps and not too close to bedtime. And you have to place your sleep knowing you type at the correct circadian timing. But knowing you type and having to live in the world means that might not always be congruent. And so there are ways in which experts can help people align their clock to be where they need to socially. An important piece to know about sleep is that sleep is an automatic process. What I mean by that is if you take a person who sleeps well and you ask them, how do you do that? They look at you with blank eyes because they do nothing. It just happens. They basically trust the sleep drive and the clock to do their job. They actually don't know about it, even they don't think about it. It just happens because that's what happens in the background. So for people who sleep well, the bed is a very strong cue for sleep. They might not necessarily feel sleepy while they're watching television or whatever they do before they go to bed, but when they go to bed, they typically fall asleep fast because the bed has become a strong cue for them to sleep. In contrast, for people who have had the experience of tossing and turning in bed, just that experience has made the bed a cue for arousal. It's unintentional, they don't plan for it, but that's what happens. So they would say, before bed, I cannot hold my eyes open, I fall asleep, I try to read, and I fall asleep. Then I go to bed and my mind becomes wide awake. They are tired, but wired. And oftentimes, because one of the components for that is that the bed has become, over time, a cue for them to not sleep, and it's just an automatic process that happens. So needless to say, you all know that an active mind is not conducive for sleep. It's not congruent with sleeping well. So the amendment of the picture that I promise you has a third component, which is you need to have low arousal and a calm mind in order to have good sleep. So taking all of this together, keep it in mind as you're asking the question, as I am answering the question, I want to move to sleep during specific times in our lifetime. So starting with pregnancy, there is an increase in time awake, in wakefulness, or multiple times of waking up among pregnant women. That does not mean that it's difficult to fall back asleep. It just means that there's more frequently need to go to the bathroom. It's hard, particularly later in pregnancy, it's hard to find a position. There are a variety of reasons for why that might be happening, but that in itself is not insomnia. Insomnia is a sleep disorder in which it's not just waking because the pregnancy woke you up, it's that you can't fall back asleep after you have been awakened. And that becomes more of a problem. Or you have difficulty falling asleep to begin with, which is unrelated to pregnancy. There's also increase in a sleep disorder called sleep apnea among pregnant women. And sleep apnea is a disorder of breathing during sleep. There is a partial or full cessation of breathing while a person is asleep that oftentimes is associated either with deoxygenation of the blood or with wakefulness, brief wakefulness that you don't even know that you have that. So the sleep becomes extremely fragmented. Having sleep apnea during pregnancy is an increase for preterm birth, and it's receiving lots of attention. There's multiple trials going on across the nation about sleep apnea during pregnancy. Women who have high body mass index, above 32 kilograms per meter square, who snore very loudly, not just softly, who experience that sleep is not restorative despite sleeping enough, are at increased risk for having sleep apnea while they're pregnant. I right now am at the fourth, almost entering the last year of recruitment for a study of women with insomnia during pregnancy using non-pharmacological interventions that I'll get to towards the end. So if you know anybody that might fit this category who have insomnia while they're pregnant, feel free to pass the information. Parenting and sleep. Well, parenting and sleep depends on the age of the child. So when the children are infants, and that's in part what we're doing in a perinatal insomnia study, we are teaching women how to deal with infant sleep, how to set the stage that an infant will develop healthy sleep. Sleep is disrupted unpredictably very initially. There's no rhyme and reason. You just need to deal with it. You're sleep deprived. If you're lucky, you're not, but most women do. What do we need to do in order to promote healthy development of sleep in infants? The idea is to promote the natural ability of an infant to learn to self-soothe. And you do that by putting the infant relatively early on, like after 6 weeks or so, in the bed environment, drowsy but awake. So they are likely to fall asleep, and they kind of learn that association. So that association, good association with the bed and sleep is what you want to teach the infant. Establishing a bedtime routine, which is also important for adults before bedtime. Basically creating lots of good cues for sleep. And the other myth, just to take from Amy's presentation about infant sleep, is that you try to tire the baby so the baby will sleep better, but in fact the opposite is true. The more tired the baby, the less it is for them to settle down and to fall asleep. During toddlerhood and preschool years, most infants sleep, most toddlers sleep through the night, but you start having behaviors when they do wake up, there are some limiting behavior issues with behaviors where the toddlers will come into their parents' bed in the middle of the night or refuse to fall asleep on their own. We work with that, but the best thing is an ounce of prevention. And technology has invented a wonderful thing that's called the toddler alarm clock. And it's basically an alarm clock with no hours, but it changes color. And you set it up to change color from whatever is the brand, from one color that signals night to another color that says it's okay to come to our bedroom now. And that has been very helpful because kids really want to do what their parents expect them, but they don't know how because they have no concept of time, right? School-age children, typically there's pretty quiet time with respect to sleep problems, except if there are problems, but most kids are sleeping well. Adolescence is where parents lose sleep, not because the adolescents lose sleep, it's because they lose sleep over what are their kids doing at night, and that I'm not even going there. So sleep in transition to menopause, very much like the idea of pregnancy, women during the perimenopausal period who have nocturnal hot flashes, that is going to wake them up. That does not mean that all of the arousals happen that way. In fact, only around 50% of the arousals from sleep, the hot flash started first, and then there was an arousal. The other maybe 40-some%, it's the opposite. First there's an arousal, and then there's a hot flash, and about 10%, it's kind of both of them happen together. So insomnia is happening just like in pregnancy when waking up from a hot flash is associated with difficulty falling back asleep. But that is not necessarily just the hot flash itself. I went through hot flashes when I went through that period, and I would throw off the blanket, I'd wake up, throw off the blanket, fall asleep, wake up too cold, put on the blanket, and that will repeat. But I would fall asleep right away. I didn't have insomnia, I just had hot flashes that interfered with my sleep. It was not the end of the world. It was. That's the good news. There's also increase in sleep apnea postmenopausally, in part because the gonadal hormone, the female gonadal hormones are protective for sleep apnea. So the ratio of sleep apnea is much, much higher in men than in women premenopausally, but the gap in the prevalence difference decreases postmenopausally in women. In part is because we lose muscle tone with the loss of the gonadal hormone as well, and the muscle tone in general creates more opportunities for collapse of the airways and obstruction of the airways. Sleep after retirement. Here I want to talk about a few pitfalls. I can talk forever about sleep and aging, a whole lecture. But I think one of the things to keep in mind is a matter of expectation. People who've worked hard and had to wake up because of work say, finally, my kids are out, I'm not working, I can sleep as much as I want. However, little do they know that if we have experiments that show that you have good sleepers that sleep 7-8 hours, and you now tell them for the next week, I want you to sleep 9-10 hours, they start having insomnia. So trying to sleep longer than what your body needs weakens your sleep drive. As a result, you don't sleep. As a result, the bed becomes a cue for not sleeping, and then you can develop into a problem. Another myth is that, and maybe not myth, but another issue that I often find among retirees is is being understimulated. You move from being at the top of the world, being active, being creative, potentially to a retirement in which that's not the case. It doesn't have to be, but you have to guard against it. So there are ways to be stimulated while you're in retirement. You do not sleep well when you're bored, or when you are not feeling fulfilled, or when you do not have a little bit of stress. It's all in the yin and the yang. And there's also age-related changes in sleep, and here I want just to show you how deep sleep changes across the lifetime. But when I was talking about the deep sleep, you all say, that's what I want. But I will tell you, that's what you get, except that when we get older, and older means already from around age 15, you start having less and less of this slow-wave sleep. It doesn't mean that you can't sleep well, because the quality of our sleep is determined more by how consolidated it was than by anything else. So how do we treat insomnia? There are both medications, and there's also cognitive behavioral therapy for insomnia. Research is showing that the cognitive behavioral therapy for insomnia is as effective as sleep medications during treatment, has more long-term benefits, and it has little side effects. And just 2 weeks ago, the American College of Physicians has issued new guidelines for primary care physicians that the first order when somebody comes to them with an insomnia is to recommend that they receive cognitive behavioral therapy for insomnia. So where do you find that help? Well, at Stanford, I direct an insomnia, sleep health and insomnia program. We are 3 psychologists who have specialty in behavioral sleep medicine. It's in the Department of Psychiatry. And we have a website called insomnia.stanford.edu that's very easy to remember. You can look us up. At the Redwood City off campus, there is also a part of the Department of Psychiatry is the Stanford Sleep Center. There's lots of physicians there and beds to have overnight sleep studies for treatment of sleep apnea. And there's also a psychologist there who's doing some of the cognitive behavioral therapy for insomnia. So I thank you for your attention. And I'll leave this slide on in case you want to